because there is a number of different factors that can be at play here, whether it be insulin, toxicity, leaky gut, when you're working with somebody, is there a certain area you start with, see if you get results, and then say it's something like leaky gut, would that be a test you do later on if they brought down the insulin and they still weren't getting rid of the visceral fat?
Great question. As a general rule, I'm very much into the gut. I'm telling you, most of the pathology, most of the inflammation that I have seen over the course of years, which has molded and changed my practice, has pointed me towards the gut. So right from the get-go, I'm always going to question your gut. I'm always going to ask you about your gut symptoms right from the beginning. I'll start right from when you were born. I'm going to be asking you questions about whether you were C-section or not, whether you received multiple courses of antibiotics as a kid or not, whether you had major GI illnesses as a kid. Did you have a sentinel event when you had a major bowel problem that could have altered your microbiome, for example? I'm going to ask you about your eating habits and how often you're having a bowel movement. What does your bowel movement look like? What does your belly feel like after you eat? So no, all these questions I'm going to ask from day one. You got a fatty liver? Okay, fine. I'm going to ask you about everything else too. But the gut is a major focus because that's where I've found that most of the derangement actually starts in the gut. So these patients will come to me. For example, I'll just give you a typical example. I'm just going to digress a little bit. 2 to 3 weeks ago, he has a calcium score of 2,500. And he's been on good statins for 20 to 30 years now. And everything looks perfect on his blood work. And he doesn't have high blood pressure. He's not an alcoholic. And yet he has all this coronary calcium. And then as we take the history, we say, okay, so why do you have so much coronary calcium? There's obviously been a problem here. You don't just get coronary calcium. So it turns out that for years he thought he had a normal gut. But he doesn't. Because every time he eats, he has to go to the bathroom. He has to go run very quickly. And he thought that was normal. And his bowels are always loose. And after he eats, he gets bloating, he gets gas, he gets distended, and he thought that was perfectly okay. And when I took a deeper history, I found out that throughout his young days, he's had major gut problems. And he's been on multiple courses of antibiotics before, and obviously this guy was having symptoms suggestive of dysbiosis, and the dysbiosis causing a leaky gut, and the leaky gut causing what we call metabolic endotoxemia. So I ended up measuring his stool examination, and I found that the gut microbiome was, of course, off the chart, but he had a lot of LPS antibodies, which is lipopolysaccharide antibodies, very strongly positive. The markers for inflammation in his gut were all positive as well. And we nailed it. We said, this is where your inflammation all came from. And then, of course, we do regular blood work. We found that his CRP was elevated. We found that his MPO levels were elevated, which is an enzyme that's in your white cells. So there was inflammation. He was having ongoing inflammation. Then we looked at his LDL particles, and his LDL particles were small and dense particles, and he also had a lot of oxidized LDL particles. His ferritin level was also elevated. So you see, I'm building a picture here that he's got inflammation in his body. And the inflammation was coming from his gut because all the other parameters were okay. So I changed his eating habits, made him go on my diet plan, and now we'll see. I mean, I just saw him, so we'll because what we want to do is to stop this process. If we don't stop this process, his calcium score will continue to rise, and one day when you get inflammation, you're going to get a plaque rupture in one of those vulnerable plaques, and then you get a blood clot in it, and you get a myocardial infarction. So you see, it's inflammation. The problem in atherosclerotic disease is this is an inflammatory condition, and the source of inflammation must be found. And when you go deeper as to what is the cause of this inflammation, it comes down to reactive oxygen species. Then you say, what is reactive oxygen species? Well, it's a problem with electron transfer. So wait a second, you're talking about electron transfer. Yes, this is all about your redox. So there's this thing called redox medicine now. And this redox medicine is crucially important because ultimately that's the mechanism by which the disease is actually happening at the microscopic level. It's all to do with the electrons. So, to explain that a little bit more, your reactive oxygen species that is being produced from this invasion from the gut, for example, or by all those chemicals, reactions going on in your liver, what do they do? So what if you have reactive oxygen species? Well, these reactive oxygen species, they destroy your glycocalyx. Now, what is a glycocalyx? Well, the glycocalyx is those little hair-like structures that are lining your arteries, especially your coronary arteries, but they're actually all over your body, including your brain. They have a negative charge on them. Now, these redox molecules, they come along and they destroy that glycocalyx. And how does it do it? Through charge. Because it's electron transfer. This is negative. These things also are radicals. So they're going to grab electrons out of the glycocalyx. The glycocalyx gets destroyed. Now you have a bare area in the lining of your artery, and it exposes the endothelium. Now this endothelial cells, which are the lining of your cells, get activated. They get activated because the protective layer was taken away. When they get activated, they start expressing vascular cell adhesion molecules, intercellular adhesion molecules, and other receptors on the walls, which then grab macrophages as they're going by. And normally those cells wouldn't be exposed to them because the glycocalyx would be protecting them. They bind to them, the macrophages get inside, and once they get inside and past the first layer, they get inside there, and then oxidized LDL comes along, and they grab it and they become foam cells inside the plaque. So the process started because of a change in your charge, negative charge, positive. So our inability to optimize our redox. So we say, well, if you're making too many reactive oxygen species, we have mechanisms to counteract them. But those mechanisms are compromised today because of our lifestyle. So today, the model that I'm seeing in my patients that are atherosclerotic disease is a disease of a problem with electrons at the level of the glycocalyx and glycocalyx damage caused by a change in the redox potential of your body because of too much reactive oxygen species and an inability to produce enough reducing agents in your body. My own body should be producing reducing agents to counteract that, and those are also being compromised. So you're absolutely right. There's things that increase reactive oxygen species. There's things that are diminishing my ability to make reducing substances. So there are multiple causes for all this. There's no one single cause. They all come together, and then you end up with the atherosclerotic process. So in that same patient, yes, he's got a leaky gut. Yes. So what happened to his own defenses of producing reducing agents? Antioxidants, your endogenous antioxidants. I call them reducing agents, you can call them antioxidants. What happened to them? They also compromised. They compromised for a number of reasons. They get compromised. It's the way we live, the way we sleep, our environment. So our own antioxidant levels go down. We're getting oxidant damage. You're getting oxidant damage, and we don't have enough endogenous antioxidants. And hence, now this is causing these problems that we are seeing with all these diseases. So ultimately, where do they all work? They all come down to the mitochondria of your cells. So your mitochondria, when they become dysfunctional, they produce reactive oxygen species. See? So all these reactive oxygen species we talk about, say, oh yeah, you got a fatty liver, it's inflammatory. It's fine to say it's inflammatory. What do you mean by inflammatory? Inflammatory means that you are producing reactive oxygen species. That's what you're doing. And you're producing them where? Where do you produce them? There are many places you produce them. Main place is your mitochondria. Why are your mitochondria making reactive oxygen species? They shouldn't be making reactive oxygen species. They're making reactive oxygen species for a number of reasons. Number one, too much substrate overload. So you basically have all the glucose that you're throwing into the mitochondria and too much substrate, and there's a bottleneck. And when you get that bottleneck, the mitochondria can't work very well. So they become dysfunctional and then produce reactive oxygen species. So, right there. Number 2, toxicity. Where does the toxicities all occur? At the level of the mitochondria. Nutritional deficiencies. Why would a nutritional deficiency cause reactive oxygen species? Because the nutritional deficiencies work right there at the level of the mitochondria. So mitochondria are not working very well because they don't see enough vitamin Bs, for example, not enough omega-3, or the proteins have been damaged by oxidative stress. Then your mitochondria don't work very well. So they produce more reactive oxygen species. So there are so many things that cause the mitochondria to become dysfunctional. So ultimately, it is your mitochondria that are producing all these reactive oxygen species, and the repair processes are compromised. And they're compromised. So we all look at the lifestyle and say, well, why are they compromised? And we see that we have all these deficiencies in the body. That, for example, your liver's mitochondria work best at noontime. So given the same substrate, they'll produce less reactive oxygen species than the same substrate, the same meal at 9 o'clock at night. So this is the circadian. So how does the circadian pattern work? This is how circadian rhythm works. Because your car works on 6 cylinders at noontime, but if you take it for a ride at 4 o'clock in the evening onward, it drops down to 3 cylinders. That's how the body is. So your mitochondrial function is not the same throughout the day. So we have created a situation through our lifestyle, what we're eating, but also when we're eating, that is compromising our mitochondria. Because they cannot handle that substrate load at 10 o'clock at night, and they'll produce more reactive oxygen species at 10 o'clock at night, but not at noontime. So lifestyle, what we're eating, when we're eating, do we have enough nutritional value to the food that we eat? All this is affecting our mitochondria. Ultimately, it comes down to the mitochondria. A lot of the diseases we talk about come down to the mitochondrial function. And the manifestation of that is going to be your fatty liver, your coronary artery disease, your hypertension, your joint disease, your premature aging. It ultimately comes down to mitochondria. If you take care of your body, your mitochondria will be working efficiently. And that's why I've always said that you got to do some fasting and change your diet. Because fasting changes your mitochondria. Fasting gives you mitophagy. Fasting improves mitochondrial function. It is the most anti-inflammatory thing you can do because it reduces your reactive oxygen species production right there. Why? Why does fasting do that? Because it improves mitochondrial function. That is why patients who fast, they say that, oh my gosh, I had so much energy, I feel so good. So part of the reason is, of course, they're running on ketones, but main reason is because your mitochondria are working better. So when your mitochondria work better, they produce less reactive oxygen species as they go through the electron transport chain, and you make more ATP. A badly functioning mitochondria will make lots of reactive oxygen species, and they'll make very little ATP. How would you feel? Drained. No energy. I feel lousy because your mitochondria are making very little ATP, in spite of the fact that you've got all this energy in the world. You've got all this stored energy. I've got 6 months worth of stored energy in my body, but I feel tired and I feel fatigued because your mitochondria are not working very well. So it's what we've done to our physiology, not this old idea of calories in, calories out, health is all related to calories coming in, food coming in. No. It's with what we've done to our physiology. What have we done to our mitochondria? What have we done to them? Therein lies the problem, that we've deranged our energy systems. So the new concept is coronary artery disease is a breakdown of the energetic system of the body, whereby we're producing more reactive oxygen species, less ATP, more and more inflammation, and less reducing capacity that we have because of our lifestyle. So it's a whole new concept when you think about it that way. And when you go back and look at the pathways of what reactive oxygen species do, it comes back also to this whole issue about nitric oxide that people talk about all the time. It's all linked. This is all linked to nitric oxide. And we can dive into nitric oxide if you'd like, but I did digress there a little bit because I was talking about the coronary aspect of all this inflammation, because ultimately my interest is to reduce the atherosclerotic plaque and the burden and inflammation within your arteries, because this is what causes death. This is what's causing premature death in the United States, but it's also linked to premature aging.
Since you made it to the end of this clip, I know you're going to love the full episode. Click here to watch. I'll see you over there.
Visceral fat is pathological always. It should never happen, but we have an epidemic of it going on right now. Estimates are anywhere between 40 and 50% of the population.